All right, so for urinary 2, we went over filtration and absorption. Now we're going to focus on secretion. We're going to talk about some GFR a little bit more and changes in blood values for nitrogenous waste that can be expected when GFR drops, as in CKD. So we'll talk about CKD today, which is chronic kidney disease. We'll talk about hemodialysis and what goals would be in regard to blood levels of those wastes and hydrogen ions and fluid balance. We'll talk about the physical and chemical properties of urine, and then we'll talk about abnormal urine components and the conditions characterized by the presence of the detectable amounts of each. So, step 3 of urine formation, and does anybody remember what the word is for urine formation? Diuresis. So this is step 3 of diuresis, which is secretion. And so it's taking all of the unwanted things in our blood and putting it into the filtrate, which will eventually become urine and excreted from our bodies. So this is just a review of reabsorption. So remember that we have obligatory reabsorption of 65% of all of our filtrate in that first part of the tubule, in the proximal convoluted tubule. And this includes all glucose and all amino acids. So you should not see glucose or amino acids in the rest of the nephron unless there's an issue. The nephron loop is responsible for making dilute or concentrated urine via the countercurrent multiplication, which we're not going to go over. And then everything in the DCT and the collecting duct is under hormonal control. So ADH, we're absorbing water through those aquaporins. Aldosterone, we're absorbing sodium, or reabsorbing sodium. And we use sodium-potassium pumps to do that. AMP, we're inhibiting that sodium reabsorption, so it slows down those sodium-potassium pumps. And then with PTH, we're reabsorbing calcium. Yeah. Sorry. I was like, what are they talking about? Okay. But this is a review, yes?
Yes.
Okay. So now with secretion, it's reabsorption in reverse. So instead of reabsorbing things back into the blood, we're taking things from the blood and getting rid of it, excreting it. So this includes foreign substances like drugs and toxins and metabolites. Many of them are protein bound, which means that they're not going to fit out of that glomerulus. We're not going to be able to filter it out during that first step, so we have to use secretion to get it out of the blood because they're too big. That includes urea and uric acid, which are products of protein breakdown. Excess potassium, we're getting rid of that to keep our blood levels low. If you remember from, when did we talk about this? Blood, I think. Our potassium levels should be pretty low in the blood, okay, at a 4. Anybody remember what the units were for this?
Microequivalent?
Yeah, so milliequivalents per liter. So we need to keep that low, and so that's why we use that sodium-potassium pump. We're putting lots of sodium in the blood, but potassium is going in the opposite direction, away from the blood. So that's aldosterone driven. And then also during this step, we're going to be getting rid of hydrogen ions or bicarbonate ions, depending what our current pH is. And that's to control our pH. And what should our blood pH stay between? 7.35 to 7.45. So these are all the things that we'll be getting rid of during secretion. And this occurs almost completely in the first part of the tubule, in the proximal convoluted tubule. All right. So in the blood, sodium stays high, potassium stays low. So we use that sodium-potassium pump to keep a bunch of sodium in the blood and potassium away from the blood. And that's aldosterone driven. This is just a little bit of history regarding antibiotics. So this is a technician from the Merck group. They're still a pharmaceutical company now. They started in like the 1890s. But what's really interesting is that 40 to 99% of the antibiotics that you excrete in your urine are actually still fully functional. So before we were able to mass produce antibiotics, we would actually pull antibiotics and filter them out from urine, purify it, and then distribute it out back to patients. This was really popular during like World War II, where we had lots of soldiers who were being injured and got infections and such and needed antibiotics. So we would just purify the urine from patients because most of it's still fully functional and then re-administer it to patients. That would take about 3 months of purifying urine to only help about 10 patients. So it was really, really slow going with the production of antibiotics. Now, obviously, we're in much better shape in that regard, but I think it's pretty interesting that we would purify urine and then just give the antibiotics back. Medicine's pretty crazy. So, chronic kidney disease, or also referred to as chronic renal disease. But chronic kidney disease is when your GFR is low. What should your GFR be around? 125 milliliters per minute. So if your GFR is low, what we mean is, oh man, I haven't used my pencil in a long time.
Finger pain.
Let it connect, okay. So GFR is low, meaning less than 60 milliliters per minute for more than 3 months. If you are at between 30 to 59 milliliters per minute, we would consider that moderate CKD. And less than 15, I'll put it over here, less than 15 milliliters per minute is considered renal failure. Now, when you have chronic kidney disease like this, where it's over a long time and you're losing your kidney function gradually, that's a permanent issue. This is a permanent disease. Now, when we talked about like marathon running and acute renal failure from running a marathon where you're not trained to do so, that's reversible. So when it's acute, it's reversible. And hopefully we can bring you back from that. When it's gradual like this is permanent damage. So with chronic kidney disease, secretion is inefficient. Your kidneys are not well enough to secrete the unwanted things out of your blood and into the urine. And so unwanted items stay in the blood. So these are all the things we talked about that we try to get rid of during secretion. So if you have CKD and you can't get rid of foreign substances like drugs and toxins and metabolites, you can overdose from having bad kidney function. If you can't get rid of urea or uric acid, you'll have uremia, which is a buildup of nitrogenous waste in the blood, which can be toxic. If you can't keep the excess potassium out of the blood through that aldosterone-driven sodium potassium pump, then you can end up with hyperkalemia, which has a lot of neurological effects to it. And then if you cannot control your hydrogen ion and bicarbonate levels, what's most likely going to happen is you're going to go into metabolic acidosis. Metabolic acidosis due to bad kidney function is much more common than metabolic alkalosis. You're more likely to build up those hydrogen ions than bicarbonate. And so with CKD, what you're going to see, some symptoms and signs: nausea, vomiting, fatigue, dizziness. This is all due to the buildup of toxins in the blood. Loss of mental sharpness. And then depending on what the issue is or what your kidney function is at the time, you may urinate more or less. Okay, so any questions about CKD? Okay, anybody still need these notes up? Okay. Anybody extra tired today? I feel extra tired. I think I'm just used to waking up at like 8:30 all week. My kids still can sleep until like noon. I can't do that.
It's because they're staying up late and you're asleep.
Yeah. I know, I got an email from a text from my daughter over spring break at like 3 a.m. that was like, Mom, I want a tongue ring. No, absolutely not, and go to bed, but I was already asleep.
She's probably half awake, she'll say yes.
Don't you have one?
I have a lip ring, I don't have a tongue ring. No. Mm-mm. But she's only in 8th grade. No, absolutely not. All right, so this is an image showing you a healthy kidney versus a diseased kidney. Let me erase these notes over here. So you can see the fibrosis, and it's a lot smaller in size due to the scar tissue and such. Okay, so dilute versus concentrated urine. This is that countercurrent multiplication that we talked about before that I said we're not going to cover, so we're not going to cover. It just gives you a visual of what's happening here. So if you are so dehydrated that you have the maximal amount of ADH being released, this is kind of the flow chart of what's going to happen. So if you're dehydrated, your osmolality of your extracellular fluids is going to go up, so you're going to be very concentrated, which is going to cause more ADH to be released from the posterior pituitary gland, which means that we're going to have more aquaporins that are going to be placed into the collecting duct so we can reabsorb more water back into the blood, so we have more water reabsorption from the collecting duct. And because we're taking all of that water from the filtrate and putting it back into the blood, what you end up with is this very small volume of super concentrated urine. So in the image here, again, you don't have to know about the math or the concentrations, but you can see here's a highly concentrated 1200 milliosmoles here and a very dark urine. If you're dehydrated, because your body wants to try to keep all the water it can in the blood, in our extracellular fluids, and so very little is excreted out, and you end up with a small volume of very concentrated urine. So questions about that? That should be like kind of review. If you are overly hydrated, this girl's drinking like 6 cups of water at the same time. So if you're super overly hydrated where there's no ADH being released, what's happening here is your osmolality of your extracellular fluids is going to drop dramatically because you're diluting everything by bringing in too much water. And we talked about before, there is a such thing as water toxicity. You can't have too much water. And so then ADH release from the posterior pituitary is going to decrease. We don't need to hold on to any more water if you're overhydrating yourself. So we're going to decrease the number of aquaporins in that collecting duct, which lowers the amount of water reabsorption from the collecting duct, so more water stays in the filtrate. We're not reabsorbing more back into the blood. So then what you end up with is a large volume of very dilute urine. Okay. So just make sure you understand that flow of how we end up with concentrated urine versus dilute urine. Any questions about that flow? Okay. So dilute urine, the name for that, having a large amount of dilute urine is called polyuria. This is really common in people with diabetes. So with diabetes mellitus, we already talked about if it's untreated, when your kidneys are processing that glucose and we're trying to reabsorb all the glucose that's in the filtrate, you're going to hit that Tmax. And you're not going to be able to reabsorb any more glucose, and whatever remaining glucose is in your filtrate is going to stay in the filtrate and be in your urine. And so when you have glucose in your urine, glucose attracts water. So the more glucose you have in your filtrate, the more water is going to also stay in your filtrate. So you end up urinating a lot. There is another kind of diabetes called diabetes insipidus. And this is where you have either no ADH secretion, so you can't reabsorb water, or your cells are not responding to it. Okay, there's no ADH response. Okay, so you have trouble reabsorbing water, and all that water stays in the filtrate, and you end up urinating a lot of it out. The difference between the two in the name, diabetes mellitus means sweet. This is a sweet urine, versus insipidus is bland, or bland urine. Doesn't really taste like much. Okay, and back in the day, doctors would actually taste the urine of their patients to see if it was sweet or not, to be able to tell the difference between diabetes mellitus and diabetes insipidus. Urine is sterile technically, and so it's not going to really harm you, but you can tell the difference. Yeah.
Would they know it was because obviously a normal person wouldn't have glucose in their urine, so how would they just use other signs and symptoms to determine that it was diabetes insipidus?
Yeah. So they would have the polyuria would be one thing. Other dehydration symptoms as well, nausea, things like that. I mean, they just go off of the information that they have, and they would be able to taste the urine. So they had our patient had polyuria, but they weren't sure if it was diabetes mellitus or insipidus. That's a test that we use to try to decipher the two, but they still only have so much information to go off of.
That's why we get paid the big
To taste people's urine. Diabetes insipidus is more common gestationally, where you can have it during pregnancy, and then usually it'll go away. But having polyuria, it can lead to dehydration because you're getting rid of all of that water in your urine and you're not reabsorbing it back into the blood, and polydipsia. Does anybody remember from your diabetes critical thinking assignment what polydipsia means? Excessive thirst, yes. Other things that can cause polyuria is diuretics. So osmotic diuretics, what they do is they use a chemical that's not going to be reabsorbed. So it gets filtered out, it ends up in your filtrate. It's not being reabsorbed, so it increases the concentration of your urine. So water is attracted to it more. And so you end up urinating more instead of reabsorbing that water. Alcohol and caffeine act as diuretics in different ways. Alcohol inhibits ADH release. So if you don't have ADH release, then you can't reabsorb more water, and it ends up in your filtrate and you end up urinating it out more. Caffeine inhibits sodium reabsorption. So if we're not reabsorbing sodium, it stays in the filtrate, and water also stays in the filtrate. And there's also loop diuretics. They're a little bit different because they work specifically at the nephron loop and not any other part of the nephron. So that includes furosemide and thiazide. The problem with the loop diuretics is your body can adapt to them. So if you are on loop diuretics, you may need to take a stronger loop diuretic eventually to get the same effects. Diuretics are sometimes abused for weight loss. It's not recommended. I don't recommend you do that for that. Because all you're doing is losing water weight temporarily, and then it comes back if you're not changing anything else. All right. Questions about polyuria? Yeah.
I didn't catch what you said for gestational diabetes.
Oh, it's more common to be gestational, meaning it happens during pregnancy, which it can be temporary in that case. Any other questions on polyuria?
So what about the little legs?
About the what?
Little legs.
Oh, so if you, yeah. Why did I bring up the legs for this specifically?
The diuretics on the bottom, it says used for edema.
Oh, yeah. So so thank you. So diuretics sometimes can be used for edema. So it can help you get rid of excess water in that way. And people who have CKD or renal failure, they're holding on to a lot of waste. So they have lots of waste in their blood and extracellular fluids, which attracts water, which leads to edema. So diuretics can be used to relieve some of that edema from the kidney disease. Thank you for that reminder. So urinalysis is not the only way to look at kidney function. We can look at their blood too. So we can look at the urinalysis to see if there's things there that shouldn't be, but then also we can see if your kidneys are not filtering things out. We can look at what's in the blood as well. So we're looking at things that are a product of protein breakdown. So nitrogenous wastes are a product of protein breakdown. And so if you have too many of these nitrogenous wastes in your blood, that means that your kidneys are not doing a good enough job of getting rid of them. So that includes creatinine, which we talked about. It's a product of muscle metabolism, and it's a breakdown product of creatine phosphate. Creatine phosphate is what we use in like the first 15 seconds of aerobic activity. Levels are not affected by your diet, so this is a pretty good marker to tell you about kidney function. But remember, we said some populations naturally have a higher level than normal of creatinine if they have a higher skeletal muscle mass than others. Urea is one that they'll test for as well. There is something called a BUN test, a blood urea nitrogen test, to see what's in your blood and to look at what your kidney function is like. But these levels may be affected by your diet. So you're going to have higher levels of urea if you're eating things like lunch meats. If you like chicken nuggets, you'll have urea as well. Hot dogs, a lot of the processed meats. Ham, bacon. Bacon, yes, that too. Can cause higher than normal levels of urea in the blood. And again, if you have CKD and you're not getting rid of these things and they're staying in your blood, and not only in your blood, but in your extracellular fluid as well, this can cause edema. It's going to cause swelling because water is going to be attracted to wherever it's most concentrated. Uric acid is a breakdown product of purines. Our A and G bases, our A and G nucleotides. When we break down those, we make uric acid. This is found in red meat, and it's mostly found, or you can find a lot of it in game meat. So if you're a hunter and you eat things like veal or venison, or if you eat organ meat like liver, you'll have higher amounts of uric acid. But also bacon and turkey will break down into uric acid as well. Having a buildup of uric acid in the blood can lead to gout. If you guys remember talking about gout in B32, that uric acid can crystallize, and it usually crystallizes around your joints, specifically in your big toe. It can cause those joints to actually fuse together, and it can be really painful. About gout? Yeah, so if you have high levels of uric acid, it can end up crystallizing, and it usually crystallizes around your joints, specifically the joint in your big toe. And it can cause those bones to fuse together, and you'll lose mobility of your big toe, which makes it really painful to walk. More common in men, I think. All right. Any questions about blood levels of these waste products? Okay. Okay, so hemodialysis is a way that we artificially filter out the blood. We do the kidney's job for them outside of the body. So what we do is we hook somebody up to a machine where it's going to filter out or take out their blood, and it's going to run it through a hemodialysis machine. So the pink on the outside is a buffer. It's a very low concentration, just has buffer in it, but the blood is very concentrated. And so it puts it through a permeable, semi-permeable membrane, where what's going to happen is that the very concentrated blood, those products, those ions and such, are going to diffuse out into the buffer, leaving the blood more clean than when it started. So you can see that here. So here is the dialysate, which is the buffer solution here. Okay, all you have really is buffer, base, to try to neutralize the acid. And because it's so low concentrated in the dialysate buffer, all of these, like hydrogen ions, excess potassium ions, sodium ions, those are all going to move towards less concentrated. It's going to want to reach an equilibrium on either side of that membrane. And so what you end up with at the end of dialysis is you'll have all of these metabolites and things that we have excess of in the buffer, and then your blood should be more leveled out than it was before. Yeah.
How often does somebody with CKD need to get this?
CKD, if you're in renal failure, so you can only get, you can only be approved for dialysis when you're less than 15. So around 12 milliliters per minute is when they'll put you on dialysis, and you'll do it a few times a week. And then depending on how bad you get, it might be every day of the week, but it all depends on where you're at as far as your renal failure goes. Another way besides this way, which you would do at a clinic, sometimes if you have enough support at home and you go through the proper training, you could do peritoneal dialysis at home. In this case, what they do is they will hook you up to an infusion, and it's usually done, peritoneal dialysis is usually done overnight. So they will infuse you with a buffer that's basically going to saturate all your organs. You'll have a port that you put it through, and it's going to saturate all your organs, and it's going to your organs are going to swim in this buffer, and that will allow the waste products to diffuse out into that fluid. And then overnight, you're going to drain it in the morning, and then now your blood and organs are more leveled out than before. And that's depending on, could be every night, depends on how bad your renal failure is. But they have to, in order to be approved for it, you have to show that you do have family support. You have to have other people in the home trained for it, and you have to train for it. So this is electronic, like it'll go by itself, but you have to be trained to do it manually too in case there's a power outage and you still need to do the dialysis. My grandma does this like every day. My grandpa's getting there too, but he refuses to do it, which is really frustrating. All right, so any questions about hemodialysis or peritoneal dialysis? Okay, pretty straightforward. So urinalysis, which is a lab we'll do on Wednesday. Your urine appearance should be clear. If it's cloudy, that can indicate that you have an infection. The color should be pale to a deep yellow. If it's reddish, that could mean that there's blood in the urine, which means there's damage to the kidneys. It could be bright yellow if you have an excess amount of vitamin C. Vitamin C is vitamin C water soluble or fat soluble? Water soluble. So this is one that's going to get excreted out of the urine. You don't hold on to any excess vitamin C. So if you're taking in too much vitamin C, your urine may end up a bright yellow color. Those vitamins that are fat soluble, where are they stored? Liver. Okay, so just don't forget that. If your urine is orange or red, it could be to certain types of drugs. I know that there is a UTI medication that can make your urine an orange color. So certain drugs can make your urine a different color than it should be. The pH of the urine is acidic, so your pH of your urine should be around 6, a pH of 6. And so when we do the urinalysis, we test for what is not expected in the urine. So things like glucose and everything that's found in the urine that shouldn't be there, you end it with a urea. So glucose urea, if you have glucose in the urine. Protein urea, if you have protein in the urine. If you have ketone bodies, like we see with people with diabetes or who are on a carb-restrictive diet, ketone urea. If you have hemoglobin in your urine, which you shouldn't, hemoglobin urea. If you have bile pigments or bilirubin in your urine, bilirubin urea. Hematuria, if you have erythrocytes in your blood. And if you have leukocytes or pus in your blood, pyuria. So if you have glucose in your blood, it could mean diabetes mellitus. If you have proteins in your urine, it could mean, it could mean excessive physical exertion, so high blood pressure causing proteins to leak out, or pregnancy can cause protein in the urine. You can have inflammation of your glomerulus, severe hypertension, heart failure. All of these things can lead to protein in your urine. Like we said before, with ketone in your urine, it can mean starvation or you're on a very carb-restrictive diet, or you have untreated diabetes. If you have hemoglobin in your urine, it could be a transfusion reaction. So if you've received a wrong blood type and you have the antibodies are lysing your red blood cells that you received, it can cause hemoglobin in the urine. If you have hemolytic anemia, which we talked about before, or severe burns can cause hemoglobin in your urine. If you have liver disease or obstruction of your bile ducts from the liver or gallbladder, you can end up with bile or bilirubin in your urine. Why you would have red blood cells in your urine, it could be due to a bleeding urinary tract due to trauma, kidney stones, which we'll talk about, infections or cancer. And then why you would have white blood cells in your urine is usually due to a urinary tract infection.
Or for patients on their menses.
Really?
Yeah, if they're on their period.
Mm-hmm.
Yeah.
They have white blood cells in there?
It'll be reddish too.
Yeah.
It could be reddish.
So your ureters, those are the tubes leading from your kidneys. They are 10-inch long, slender tubes. They have a posterior lateral entry into the bladder, so they're on the sides, on the posterior side. There is a structure within the urinary bladder called the trigon. So you have three passageways in that area. So you have the two entries for the ureters, as well as the exit for the urethra. That's the trigon. It's like a little triangular outline there. Kidney stones. So kidney stones are caused when minerals come out of solution and form deposits or stones or crystals in your calyces. So your major and minor calyces, which you can see over here. The minerals that most likely cause kidney stones, calcium being the most common, can also be magnesium salts or uric acid. Any of these can cause kidney stones. Now, calcium is going to be the most common. Calcium causes what we call calcium oxalate stones. And it's usually not caused by too much calcium in the diet. It's usually caused by not enough calcium in the diet. So if you have a high oxalate diet, or even a high salt diet too. Oxalate, where we're going to find it in, vitamin C will find oxalate, nuts will find oxalate. Very specifically, chocolate soy milk will have oxalate. If you like miso, that will also have oxalate, and beets. And so what ends up happening is, so when you have lots of oxalate in your diet, and you don't have enough calcium in your diet, what's going to happen, so if you have enough calcium in your diet, the oxalate that is coming from your food is going to bind with the oxalate in your intestines, and that's not going to cause kidney stones because they're bound together. It's too large. It's not going to cause kidney stones. You're going to end up either absorbing it or getting rid of it. And so what ends up happening if you don't have calcium in your diet and you don't have that oxalate and calcium meeting up in your intestines, that oxalate is going to move on to your kidneys where there it will meet up with calcium and cause stones. So if you don't have enough calcium in your diet, that oxalate again is going to move on, form in your kidneys, bind with calcium and cause those kidney stones. So you don't get kidney stones from having too much calcium in your diet. It's usually from not having enough. So your oxalate and calcium meet up at the kidneys causing stones. But again, it can be caused by magnesium salts and uric acid too, but more than likely it's going to be calcium oxalate stones. Which calcium we get a lot from dairy products, so you might be more likely to form calcium oxalate stones if you are lactose intolerant and not getting enough calcium from dairy products. But you need that calcium oxalate to bind together in your stomach and intestines, not in the kidneys where they can form stones. And these stones can be very, very painful. They can block a calyx. They can, your pelvis or the renal pelvis, the ureter, or they can develop in the bladder as well. How we can look for them is through an intravenous pyelogram. So we inject you with a radioactive dye that's going to go through your body, go through your kidneys, be filtered out. You're going to urinate it out, and then we can do an x-ray. And then we can see where that intravenous dye has flowed to. And then the x-ray that we take is a KUB. That's your kidneys, ureters, and bladder all in one film. And so you end up looking like this. So this is a intravenous pyelogram. So you can see the green, the radioactive dye. It went through the calyces to the ureter and down to the bladder, and so we can trace where that dye has gone. And so in here, you can see on this side, on the patient's left side over here, you can see the ureters going all the way down. But on the right side over here, you can see the calyces in the start of the ureter, but then it stops. Okay? So that can indicate that there is a blockage, that there's a stone high up in the ureter, which is why you cannot see anything going forward, because there's a blockage and the dye wasn't able to get that far. It was on this side, but not on that side. And so the ways that we can treat these kidney stones is lithotripsy, where we use sound waves, ultrasound waves, to break apart the kidney stones, or laser treatment as well to break apart the stones. Surgical removal as well if it's bad enough or large enough and can't get rid of them through the lithotripsy or laser treatment, or let them pass on their own. And these are very, very painful. Like, worse than childbirth. I had kidney stones while I was pregnant. It was not fun at all. I had to be hospitalized for like 10 days because, well, one, I was vomiting a lot from the pain, and so dehydration. And because of the pain, they had to have me on, Percocet, which is really strong. And I was pregnant, so they had to monitor the baby that whole time. It was awful. It was awful, awful, awful.
First or second?
Huh?
First or second?
My first one. And I was away at college. I was in Irvine. And oh my God, it was such a horrible thing. I was very, very lucky that my now husband was out visiting me at the time. So at least I had somebody with me, but it was so scary. So this is lithotripsy. They use sound waves to break the stones into smaller pieces so that they're easier to pass. Or we can use a laser therapy as well. So they stick a catheter up and with a laser attached, and they use the laser. You can see the big stone on A and B. You can see where the laser is pointing to be here, and then it breaks it down into smaller pieces. And then you can scrape it out so that you can get rid of them. Where is that one? Oh, there it is. That is what is painful. Do you see that stone like scraping its way through the ureter? Because it can be pretty large. You can see it's bulging out. That's it's so painful. Worse than having a baby. All right, your urinary bladder. This is an expandable muscular bag. It is expandable due to accordion-like folds within it that we see in another organ. What do you think those are called? Rugae. So you're going to have rugae in your urinary bladder as well. Where's the other organ that we have the rugae in? Stomach. Okay. Medical condition associated with it is cystitis, so inflammation of the urinary bladder, most commonly caused by bacteria. In that case, we call it a bladder infection. Other causes of cystitis are reaction to drugs, hygiene sprays, spermicidal jellies, or the use of a catheter can also cause cystitis. And so you can see that here. This is male versus female here. But here are the rugae, the folds within it. That's the rugae. You can see the trigon as well. The ureters enter through the back lateral edges, posterior lateral edges of the urinary bladder as well. And then we'll get into the urethra next. So the urethra is going to control urine flow. So just like with the digestive system and the anus, we do have internal and external urethral sphincters. So So the internal one is controlled by your autonomic nervous system. That's going to give you the urge to want to go. And then the external is going to be controlled by your somatic. It's going to be skeletal muscle that you control on your own. Okay? There is a difference in urethra versus male versus female. I'm sure you all are aware. A female's urethra is only about 3 to 4 centimeters long. Male is about 20 centimeters long. So about 1.5 inches versus 8 inches long. Okay. And we're going to get into urethritis and UTIs right now. And females are more likely to contract a UTI. One, because their urethra is closer to their anus. And because it's shorter. It has a lesser way to travel to get to the bladder, to the ureters, and so on and so forth. Males are less prone because their urethra is external versus the females, which is internal. And one thing about males as well that you should know about the male urethra is it has dual functions. That urethra is both for urine and for sperm. Any C's? What is it going to come out? So, urethritis is just inflammation of the urethra. UTI is a urinary tract infection. And make sure you know females are more prone, like we said, because their urethra is internal and it's closer to the anus than the males. Sexual activity and the use of spermicides increase risk of UTIs. Catheter use also increases your risk of a UTI. If you have a UTI, you're going to have increased urinary frequency. So you're going to have to urinate more frequently. You may have dysuria, which is painful urination. And it may cause blood-tinged urine or also foul-smelling urine due to the bacteria. Now, if you don't treat a UTI early, that UTI is just going to spread further and further up your urinary tract, and it can spread all the way up to your kidneys. And when it spreads to your kidneys, we call that pyelonephritis. And along with the symptoms we already talked about, signs and symptoms, you'll also have fever. And it's treated with antibiotics. Which can then cause digestive issues. So UTI is just not fun.
You can have a fever with just UTI as well, correct?
Yeah. Anytime you have an infection, you can have a fever. Yeah.
I'm sorry. Earlier you did say that the internal sphincter is autonomic and then the
External is somatic.
internal is autonomic?
Yes. Internal is autonomic and external is somatic.
Thank you.
Yes, ma'am. We're going to bring that up in the next couple slides as well. So any questions about urethras or UTIs or anything like that? Okay. All right. Micturition. So make sure you know diuresis is the forming of urine, while micturition is urinating or voiding. And like we just said, Susie, up here, ANS is going to control your internal urethral sphincter. Your somatic nervous system is going to control your external. So what kind of muscle makes your internal urethral sphincter? And then what about for your external?
Skeletal.
Skeletal. All right, and here's the flow for that. I'm not going to test you on this exact flow. It's just very, very similar to the defecation reflex we talked about before. So it's going to start off with your urinary bladder filling, stretching that bladder wall, elongating those rugae, and that's going to send messages from those stretch receptors or mechanoreceptors to your brain. And so your brain is either going to turn on the Micturition center, which is going to allow you to urinate, or the storage center. So if it's not convenient for you to go and you want to hold it, then that's going to trigger the storage center, which is going to decrease parasympathetic activity, increase sympathetic activity, and increase your skeletal motor nerve activity. And that's going to inhibit you from using the restroom. Okay? But if it is convenient for you to go, or if you've built up so much pressure that you got to go, what's going to happen is you're going to have an increase in parasympathetic activity and a decrease in sympathetic, and that's going to cause your internal urethral sphincter to open. Okay? But then it's going to count on you to relax your skeletal muscle to allow for your external urethral sphincter to open and allow you to urinate or micturate. So the biggest thing is to know which nervous systems are controlling what, okay, and how, and the difference between your internal and external. So urinary incontinence. In adults, it's usually caused by weakened pelvic muscles, which this can be caused by childbirth or pregnancy. Moms get all the fun stuff. But it also be caused by surgery or nervous system issues. And there's a couple different kinds of incontinence. There is stress incontinence. So this is like, let's say someone just had a baby recently and they sneeze really hard and some comes out. That's stress incontinence. Or I couldn't jump rope for like a year after I had my babies because that can make it happen as well. But then there's also overflow incontinence where you hold it for too long and then your sphincters just can't take it anymore. So stress incontinence, sneezing, coughing, jumping, just excess pressure and movement versus overflow incontinence because your bladder literally is just overflowed too much and can't hold on to it anymore. Then there is urinary retention, where you're not urinating and you're holding on to that urine. This is common after general anesthesia, that you can't urinate for a little while, which is why they make you go, number one. Number two, before you leave a hospital, make sure you regain that function. Also, if you have hypertrophy of your prostate. So if we go back and look at males versus females, and this is common in males as they get older, like older than 60, the prostate can hypertrophy. It can grow larger than it should. And you can see there's part of the urethra that runs through the prostate. And so if the prostate enlarges, that's going to narrow that urethra and make it harder for urine to pass. Okay? So you can have urinary retention from an enlarged prostate, which enlarged prostate doesn't always mean cancer. It can, and we'll talk about that with male reproductive, but that can cause urinary retention. Let's see. Yeah, when they put you on anesthesia, that's why we give you have a catheter put in to allow you to urinate during that time. Then when they evacuate the catheter, they like you to go to the restroom before you actually leave the hospital. Polyuria is where you urinate in excess of 2.5 liters a day. Oliguria is when you have less than 500 milliliters a day or less than 30 milliliters in an hour. This could be due to fluid loss, so you just don't have enough fluid to give. Could be due to an obstruction or due to renal disease. If you stop urinating altogether, that's called anuria. And we actually still have a lot of time left. So I'm going to have us move on to reproductive because female is a lot. So I would rather us get ahead than behind. So, you want me to make a new one to separate them? Yeah, I can do that.